Our next plenary session is on a highly timely theme, medicine in the age of complexity. I have the pleasure of inviting our chairpersons, Professor Namal Wijesinghe, President-elect of the Ceylon College of Physicians, and Professor Mumtaz Patel, President of the Royal College of Physicians. Please welcome them on stage.
Good morning. We'll move on to the second plenary. This on medicine in the age of complexity. I invite Professor Jennifer Martin, who is Chair Professor of Pharmacology, Newcastle University. Over to you. Yes.
We're good to go there. Thank you. Firstly, apologies I didn't make the session last night. I really missed a great opportunity to meet you all, and looking forward to catching up today. We've always had a really good and close collaboration between CCP and the RACP, which covers Australia and New Zealand. We have a lot of physicians who started their life in this part of the world, and it's actually awesome to see a lot of our own RACP physicians that started their journey here that are actually at this meeting today. So fabulous, and I look forward to catching up with more of you as the day goes on. Today I'm talking about medicine in the age of complexity, and it's quite a complicated topic in a way because we're talking about clinical decision-making and ethics and system navigation. So I changed the topic to make it, I think, a bit more straightforward in terms of the sort of challenges we face every day on the wards. It's really, how are we going to navigate best care in a system that is fragmented, a system that is underfunded, and requires constant ethical trade-off? So I'll be talking about some of these issues during the talk today, and I think that hopefully when we get to the end, we'll have some ideas about ways that we can actually still deliver the best patient care that we can, but being really cognizant of the huge geopolitical issues that we face every day and which are making our roles actually significantly more complex. And Dr. Patel has already highlighted some of these, but I'm going to go into depth the ones that are actually really important for us down under, so Australia and New Zealand. These are global health system issues. And if we start just with workforce, we can see that we're seeing huge shifts of global medical workforce across the world. Significant numbers of physicians coming out from the UK, significant numbers of physicians coming from from South Asia, from Africa, and from many other countries in the South Pacific. There's some significant ethical issues that arise with that. Firstly, who would stop somebody going if they wanted to earn more money, or if they wanted to work in an area with less conflict? And if you could get less conflict and higher pay and nice beaches, why wouldn't you go? But the ethical issues that arise are that we're leaving countries, often poorer countries, without physicians to actually serve their population. And I've got there in the top little picture, a picture of New Zealand. It's actually my hometown. So we feel in New Zealand that actually we suffer also from geographical imperialism because the conditions are so much better in Australia than New Zealand. Many physicians train in New Zealand and then move to Australia for those conditions. For those conditions. New Zealand's health system is at a real crossroads at the moment, with significant numbers of doctors in Australia, and many of the doctors that come out through the New Zealand system, because it's easier in terms of the ability to get citizenship, the ability to get into Australia, will stay in New Zealand where they get significant input and support from their physician colleagues. And by the time they finish their supervision, will actually be in Australia. So this is actually having a significant effect on the physician workforce in New Zealand. Our college covers both Australia and New Zealand, so this is a major issue for our college and something we really have to face. We also tend to take doctors and physicians from Southeast Asia and from the Pacific. And I'm not sure how many of you have worked in those countries. I have, Samoa, Fiji. There's often only one physician for the whole hospital. And when that physician decides to come to Australia or New Zealand, it's good for that person and their family potentially, but we're really contributing to the inequity that we've got in the physicians that provide that healthcare. In addition, it's very clear that Australia is not training enough. We are not training enough physicians. We're not training enough doctors. Instead, we're relying on other countries to train doctors and then poaching them for better conditions. And I'd challenge you to think about the ethics of that, particularly when the cost of training a doctor is significant to a small country's budget. We've also seen a flight from smaller, resource-poor areas in Australia and New Zealand to the metro sites. This has been called geographical narcissism. And by that, I mean that the policy is actually made in the metro centres in terms of what's best care. And when our physicians in the rural areas don't make that because there isn't funding or there isn't staff, they're actually treated not so well and often judged for their inability to deliver the care that you might be able to be delivered in a metro centre. This is actually really increasing our inequity, and for populations in Australia and New Zealand where there are significant racial groups, particularly our Indigenous people, these groups are suffering significantly more than others. So I think what I was trying to say here is these cause major equity issues, even in wealthy countries. And again, when we look at the people that are coming to Australia and New Zealand from overseas, these are often not people that have come from poor families or families that have had socio-economic inequity. These are often very wealthy families that have a long history of medicine and support and opportunities, and they know how to make sure that they get out to Australia or New Zealand. So that, I guess, gives us another equity issue. Sorry about that. There are major other challenges here too. The complexity of disease. We're seeing diseases that we never saw before. Some of these driven by obesity and diabetes, and the end results of those. That can include things like polypharmacy or harm from therapies that have never been studied in population groups where people have a body mass index of over 40, or people with type 2 diabetes that have actually got multi-organ disease everywhere and are unable to manage their disease as an outpatient. Particularly in Australia, but also in New Zealand, we're seeing destruction of our environment, complete destruction of areas where we catch fish, where we source clean water. And you might have seen recently the outbreak in South Australia of an algal bloom, which essentially took out all of the fish in that part of Australia, and has actually been an issue that's been going on for more than 3 months now. This is taking away livelihoods. It's also taking away parts of the food chain. So even when the algal bloom settles, if it does, we actually can't replace that food chain. So a lot of our, again, poorer people that live on the coastal areas that really depend on having fish and clean water are actually increasingly disadvantaged. We have a lot of underfunded core services in the rural and remote areas, and I've called that geographical narcissism. I think that's probably a worldwide issue, but certainly the healthcare and the health outcomes we know are much better in the big metro sites. We've also got this issue of patient need and want, and I'm not quite sure if it's just our part of the world or this is a global phenomenon, but when we train as physicians, usually we're dealing with the need on the ward or the need for the patients. Now we've got an active community of people who are actually wanting things that we actually don't have funding to provide. For example, the GLP-1 receptor antagonists. I mean, who wouldn't want to take a pill to lose weight if it meant you didn't have to exercise? But the reality of these drugs is that they're really expensive, and in some hospital budgets will actually blow the budget. So we don't have funding then for chemotherapy drugs, for example, or some of the newer drugs for cardiovascular disease. We have a real problem with inequity of payments to physicians in Australasia, and I do understand that's a global issue as well. So particularly in Australia, if you can do things, if you can do technical, if you have technical skills such as a surgeon or a physician that does things with scopes and that, you can actually be reimbursed quite a large amount of money. If, however, you're like me, a general physician, and you think a lot, or a geriatrician or palliative care, the incentive for those consultations is very low. And increasingly, you can't get through one of those consultations in under an hour because of the complexity of disease and the social determinants of health. Dr. Patel mentioned these significantly, and I think increasingly we're starting to realise that the social determinants of health need to be funded. We need to look at housing, we need to look at food supply, we need to look at transport, and that's really affecting health outcomes. So at the end of the day, how are we going to work as physicians in these places where we've got all of these issues going on? Well, I guess we've got to have some sort of ethical trade-off, but that means we need to know how we're going to make a decision and ensure that that decision is justifiable and reproducible. But I do note that we probably are already making such decisions every day. I mean, do you offer a therapy to a patient when you know your hospital is not going to be able to fund it? What that does lead to, though, is moral distress and burnout, and we're increasingly seeing that, as Dr. Patel mentioned in her talk as well. Doctors that are just leaving the profession for good. They're not moving to the beach, they're gone. And that's a really big risk for us. So the question then is, how do you develop your own ethical framework? Who do you decide who to and how to treat? Well, I think it's really coming back to basic stuff we probably learned in medical school a long time ago. What is need? And who defines need? Do you define it from your social class or your ethnic background or your expectation about what a government should do for its people? I talked about want already, and we're increasingly seeing these GLP-1 receptor antagonists leading to inequity across both countries. We all have physician biases. I call them isms. We know that in our college, for example, we have a significant issue with racism, and we're calling it out. Publicly, we investigated our college and put a report out which acknowledged that we have a problem with our training, our selection onto specific pathways, and also the way our exam is run. And we're fixing it. But there are other isms. How do you predict who would benefit? And by how much? And if you have limited resources, how do you have a framework that helps you decide that? We also have an issue, particularly in Australia, not so much New Zealand, but it's really becoming quite Americanised in the medico-legal side of things. So that is to say, if you're a general physician in a small town in Australia and perform an episode of care and something goes wrong, you're actually judged then by a metro physician who would be doing many of these interventions or episodes of care every day. That means people don't want to work in those areas because of the medico-legal risks, and that's actually significantly affecting our provision of care. New Zealand has ACC, which is actually a government-funded insurance scheme that protects against the medico-legal system. Increasingly, and I'm seeing this in our younger physicians and even the pre-physician group, is unwillingness to do anything. We know what needs to be done. We know the patient needs things, but there's kind of, maybe I'll call it a ditheriness, I don't want to be too rude, but it's people unwilling to do something because they know whatever they do, there'll be risks and outcomes. And so people say, oh, it's best to do nothing. And I find that really difficult because I think we should be able to think scientifically about something, be aware of our biases, understand what the patient's goals of care are, and really work with them and communicate to them the risks and benefits for each of the interventions. That's a new issue I think we're seeing. And then we talk about patient autonomy. So when I ask people what we should do, someone says, oh, well, just ask the patient what they want. But then I think, well, do they really know? We can give them as much information as we can, but it's asymmetric information. We don't know how that person takes that information and then processes it. So I guess within a fragmented health system and with inaccessibility to physicians for many patients outside the metro sites in Australasia, this is really quite problematic. And it comes back to us social determinants of health. Anyway, I had a go at thinking about the ethical principles that we teach our colleagues and that we have quite robust discussions on sometimes on the ward. Are we just trying to do good, or are we trying to avoid harm? Obviously, for each patient, things will be different. But some people actually aren't even aware of the decision-making framework they're using to make a decision. And it's not that one's right or wrong. It's just that we're not very good, I don't think, at actually identifying the principles that we're using when making a decision. I think we know how governments make decisions. They're very consequentialist approaches, maximum benefit for the input. So we just want to maximise our health outcomes. So if we're on NICE or PBAC equivalent, and we're making decisions about whether to list a medication, this is how much value will we get for our population if this drug is publicly funded, versus all the time I'm sitting there thinking, I reckon I've got a patient that would benefit from that drug. But in a government role like that, it's really much more of a consequentialist approach. And nobody shies back from that. I think it's just not often all that well discussed. Now, I'm probably going to get in a bit of trouble here with talking about Big Pharma. I think we probably could skip over this because we all know about Big Pharma. But what it really means is that we ourselves need to have a really good ethical decision-making framework, and that will really to focus us on the benefit for this patient who's often outside the groups that are studied in the clinical trials. But really to think about that, because actually it's quite pervasive, the Big Pharma input. And I've been caught out myself, actually, not even realising that Big Pharma has subtly got into my decision-making. And I think we always have to be able to question ourselves and question each other. This is another issue I think is really increasingly affecting us in terms of our ethical framework. This is how terrorists work, and here's Trump coming back to bite him. But I think pharmaceuticals, there's so many ethical decision-making issues that are part of being a clinical pharmacologist, and actually as part of being a general physician on the ward. But I think pharmaceuticals really demonstrate loud and clear the ethical pressures and the that are on us when we're trying to make these decisions. And particularly when we know that we're dependent on the US, for example, for something, or for selling to the US an API, that's going to make it quite expensive for us. How do we actually manage that? In Australia, there's certainly been discussions on manufacturing medications itself being completely non-dependent on the US. In a way that kind of helps because the cost of the medications will be a lot lower. We can probably do a marginal cost of production. But certainly I think these are geopolitical issues that we have no control over, but really affect the ability of us to make those decisions on medications. I've got 4 drugs here that I thought were big ones. I'm not going to go into all of them, but I just wanted to show them because I think these are the ones, as a clinical pharmacologist, that have really affected those equity issues or touched up on some of those principles and boundaries over the last year. The first is andexanet alpha, and you know the cost of that. So this is to reverse a factor 10A inhibitor, either an overdose or just people that bleed on it. And actually the randomized control study didn't show any benefit. In fact, it showed worse mortality, worse adverse events, 5-fold increase in clots, etc. However, we still get, quite commonly, we get pressure to actually provide this drug. And we've actually got you can look at that, that's the KTAG. It's our Council of Australian Therapeutic Advisory Groups who got together around Australia to essentially put a position statement out based on the evidence and to push back on industry, because industry were managing to get into our hospital and provide it to some of our physicians, and those physicians then started lobbying our funding partners. The new Alzheimer's drugs, I'm not sure if they're around here, probably not because they're incredibly expensive. And from my humble opinion, don't really do a lot. They're called miracle drugs. They have some statistical difference in short-term management on plaques. But actually we know that the plaque formation is the end product of an inflammatory biological pathway that started many years ago. So we're really just interested in watching that and to see the clinical outcomes from those patients. But the way the industry is lobbying us, we're made to feel, I think, as if we're doing something wrong if we don't provide these absolutely rapaciously funded drugs on our schedule. And I'm not going to talk about GLP-1s because we are moving on for time here. Since I've done 18 minutes, is that right? Yep. Oh, yeah. Okay, great. So I've got about 10 minutes to go. The GLP-1 drugs, I mean, it is it is right that they do deliver impressive long-term improvements. But the problem is that the current prices far exceed accepted thresholds for cost effectiveness. So you might say, well, why don't you just drop the price of the drug? I mean, it can't be that hard by the time you sold millions and millions of these to actually manufacture it at a marginal cost of production. But yet, wealthy governments around the world, including Australia, are still paying the list price for these. And yet we know they're patients that will benefit. It's also led to an equity issue because it's very hard to get these if you don't live in a metro site. If your local hospital has got 3 doctors and a very small budget, that hospital's not going to be able to provide this drug for you, and the cost is so much that people won't be able to provide it themselves. So I think we've got to think about that as well. These drugs might look good, but who actually gets them? I think we know the patients that can afford them, and we also know those that can't. But that's an incredible equity issue I think we really need to look at. This is an interesting piece of work. There's a lot of work by Jennifer Huang. She's a primary care physician in Chicago, and she's actually looked at the overall cardiovascular benefit or cardiometabolic benefit from these drugs, and has essentially worked out that the maths doesn't add up. So for the actual health outcome we're purchasing from these drugs, if you use the same methodology that we would use for an antihypertensive, it is costing us logfold more money for these drugs for the same cardiovascular benefit. So really, the health economics just doesn't add up. The price should be dropped. Health technology assessments, I know you have your own here too. We have ours in Australia, PBAC, I referred to that. New Zealand has PharMac and NICE in the UK. This is what we need to use. These are pathways or systematic evaluations which actually measure and relate everything on the same framework. That means that you can compare a health outcome from a GLP-1 receptor antagonist to a health outcome from an antihypertensive. And that, I guess the point of that slide was really to say, if you're really worried about these pharmaceuticals, you just need to look at it from an HTA perspective, and you'll see the actual money you're paying for a health outcome. So some of this is addressed in different countries in different ways, using different ethical formats. But from a pharmaceutical perspective, there's also different pricing models that have been used to ensure the maximum people get access to a drug that works, and that we don't use it in those patients who don't get access. So there's different pricing models, there's country-specific roadmaps, there's a lot of other aspects such as clinical input and clinical support for these processes, local manufacturing, which means that you don't necessarily need to pay the list price from the US, and you can manufacture it yourself. It provides jobs and growth. And then the way you do price and reimbursement. And as someone who sat on New Zealand's PharMac for 10 years, I was shocked when I came to Australia and found out how much Australians were paying for the same drug. And that's to do with New Zealand's ability to actually negotiate hard on the health outcomes it's buying. I wanted to put this up also from PharMac. You should have a look at it if you're interested in it. So PharMac doesn't take into account just health economics. It actually has a whole lot of other ethical principles that it takes into account before deciding whether a drug should be funded by government. They call this factors for consideration. Obviously, Maori people, our Indigenous people of New Zealand, have health outcomes that need improving and investment in, and that's the highest priority because of our commitments under the Treaty of Wijesinghe, which was the treaty signed when the British entered New Zealand. But there's also health benefits, costs and savings, sustainability and need, and lots of other aspects under each of those. But I think it actually leads to quite a robust discussion because you do your health economics and then you take into account these factors for consideration. For example, will our Maori people in the bush be able to access this drug for heart failure? If you need to have an echo before getting it, these people aren't going to get the drug. So I think the PharMac system is actually pretty good, and we encourage you to look at that. I apologise that this has got a lot of words on it, but essentially it's just reminding us that there's lots of complexity and ethical dilemmas in pharmaceuticals. And I think because we're often in a hurry, we're thinking about the patient's got this, they need that drug. We're not sitting there thinking about, what are the commercial interests here, or should we not use this drug and actually stop another therapy that they're on, and then we can use another heart failure therapy, for example. But there's a lot of ethical dilemmas that are there that we should really be cognizant of, I think, when we're making those decisions. the patient autonomy and trust. And I must say I was kind of a little bit late to this patient autonomy. I think I was nearly a physician, so in the late 90s, and we had a fabulous lecture. And I thought, I'd never actually asked a patient if I give them this drug, would they take it? And I know it seems pretty basic, but it's actually one of many things that I've learned in my journey, which is actually to say to the patient, what are your goals of care? Do you want us to actually treat this cancer and investigate it? Or would you like some other treatment or intervention or palliative care that can actually help you? I think we just grow up thinking that, yeah, we'll just do all the things that we can do to help this patient without actually asking the patient whether they want to be helped. So I think I do that now across all of the areas of medicine, and we really encourage it as well with our physician trainees to really think about patient autonomy and trust. And I know Dr. Patel talked about that trust as well. The trust is important. People believe in you, that you're going to do the right thing for them, and it's incredibly critical. And sometimes even saying to them, I know you want that expensive drug for cancer, but it's actually not going to help you. If people understand that you're trying to do the right thing for them, I think that goes a long way. So the last thing here really is how are we going to navigate? There's lots of slides here, but they all say the same thing. Essentially, you have to develop your own ethical framework and principle and be able to hold your ground, I think, when you're discussing with colleagues why you are or why you aren't going to do things. An ethical framework helps if you're in charge of something else in the hospital or community, such as access to ICU, such as access to the funded medication list. You've got to really know how you're making those decisions, and that it's actually that's actually robust. There are codes of ethics in many organisations, and they can sometimes help. I think our professional code, and we have one, as you do as well, our professional code of practice around ethical conduct. Sometimes these things clash, so that's when you've got to be able to know how to prioritise or rank each of those. But I've just come down to really this whole professional standards, ethical frameworks and principles, and the collaboration. So collaborating, as we heard before, is actually key because it keeps you really honest if you have to argue and defend and discuss your proposed course of action with other people. So in the last two slides here, the last one I want to talk about was chronic disease and comorbidity. Luckily, I've already talked a little bit about that because I noted that we're increasingly seeing chronic disease and comorbidity, and we can't stop it. It's going to get bigger. But how do we actually then rationalise our use of interventions, imaging, pathology, pharmaceuticals? And I've just got this plan here, which I think it's not like something innovative I've thought of. It's just really, I think, what we do on a day-to-day basis. But how we do it, I think, is really important. So what are the goals of care? As I said before, these are not the doctor's goals of care. These are the patient's goals of care. So what does the patient want? If we look at all of the therapies and drugs that the patient's on and their interventions, their regular chest x-rays for screening, for example, which of those still align with the goals of care? Can we stop the drugs? Can we reduce the dose? Can we simplify the way that they're getting these therapies? I think before starting new medicines, there are lots of non-pharmacological options that we should think about. But I'm amazed when I come in sometimes after being on call overnight, and all my patients, the junior doctors, have been trying to fix everything overnight with all sorts of new drugs. And I'm like, the patient doesn't want any of these things. They just want their diarrhea settled and go home, or they just want their pneumonia settled. We don't need to add all these therapies for their heart failure because they're actually at the end of life and this is their goal of care. So in conclusion, I think we just need to really be cognizant of the fact that every day we're going to have to make choices and trade-offs. And although there is moral distress in that because we can't do all the things we want to do, I think the lesson is really to think about how we can feel comfortable about doing what we can in those instances. So I think review the goals of care, review our current therapies and plan, and to make sure that we all get upskilled to improve our productivity. And lastly, the purpose of today, which is to network and collaborate. Thank you very much.
Thank you, Jennifer. Ladies and gentlemen, there's Professor Jennifer Martin. She's the President and the Chair of Royal Australasian College of Physicians. Let's appreciate in the usual way. Now I invite Professor Mumtaz Patel to hand over the certificate of appreciation. Thank you.